Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. Today's episode is on hematology physiology. And now, before we dive deeper into this episode, first of all, Maddie, congratulations. ICU Primary Prepcast has completed its 50,000 downloads, which has been a quite significant achievement, I must say, in last 2 years.
Oh, yep, that's good news. In it for the jokes.
That's right. I think, the credit goes to your jokes. Thanks to all listeners, because without you, I guess this podcast wouldn't have been reached to the stage that it is today. So thank you. Now, hematology commonly asked questions in primary exams, both in written exam and in terms of Viva. So let's start with a very basic question. Maddie, can you please briefly outline the components involved in hemostasis?
So hemostasis is the natural process which allows circulation to respond to vessel injury in a way which minimizes blood loss. There are three main components of hemostasis: vasoconstriction, formation of a platelet plug, and formation of a stabilized blood clot via the coagulation pathway. Firstly, vasoconstriction occurs. So any trauma in the vessel wall causes local myogenic spasm and local factor release from traumatized tissue and platelets, as well as nervous reflexes initiated by pain impulses. This results in smooth muscle contraction and vasoconstriction. The thromboxane A2, which is released from platelets, is responsible for much of the vasoconstriction, and the more severe the trauma, the greater the amount of spasm. Vessel size is also important. Vasoconstriction may be able to stop the bleeding in small vessels, and it reduces the blood flow in medium to large vessels, thereby reducing blood loss. The second step is formation of a platelet plug. We have outlined these steps briefly in a previous podcast on hematology pharmacology, but to recap, formation of a platelet plug requires platelet adhesion, activation, and aggregation. Endothelial disruption exposes subendothelial connective tissue to which platelets adhere via glycoproteins and von Willebrand factor. Platelet adhesion results in degranulation and activation of substances, including ADP, von Willebrand factor, phospholipase 2, and thromboxane A2. These substances promote platelet aggregation, vasoconstriction, and provide positive feedback for further platelet activation and adhesion. Platelet aggregation is mediated primarily by fibrinogen, which binds to glycoprotein 2b3a receptors on platelets, forming a platelet plug. The final step is formation of a blood clot via the coagulation pathway. This occurs in 15 to 20 seconds in severe trauma and 1 to 2 minutes in minor trauma. The platelet plug is converted into definitive clot by fibrin. Formation of fibrin involves a number of reactions and clotting factors. The fundamental reaction being conversion of soluble fibrinogen to insoluble fibrin.
Thanks, Maddie. And this has been asked as a long question in previous primary exams. And the question can be asked in a various formats. Say, for example, somebody has performed the venipuncture and has caused the trauma or injury to the vessel, and now describe how the bleeding stops at that site. So I guess the examiners are expecting to outline the steps and kind of dive deeper into each step of hemostasis. Now, as you mentioned, the final pathway is the formation of clot via coagulation pathway. So can you please describe the coagulation pathways?
So the coagulation pathways consist of two pathways, the intrinsic and extrinsic pathway, which join to form a final common pathway leading to formation of the fibrin clot. The intrinsic pathway is activated by contact with negatively charged surfaces such as collagen and subendothelial connective tissue. It starts when plasma factor 12 interacts with these negatively charged surfaces and forms a complex with the exposed collagen, prekallikrein, and high molecular weight kininogen. This complex then activates factor 12, becoming factor 12A, which then activates 11 to form 11A, which then activates factor 9 in the presence of calcium to form 9A, which in the presence of factor 8, calcium, and platelet phospholipid activates factor 10 to form 10A. The extrinsic pathway is an alternative mechanism for activation of factor 10. tissue factor found on the surface of perivascular tissue cells binds factor 7. This activated factor 7 or factor 7A and tissue factor complex then activates factor 10. This complex can also activate factor 9, which then, through the intrinsic pathway, also activates factor 10. The common pathway consists of activated factor 10, or 10A, which in the presence of factor 5A, calcium, and platelet phospholipid converts prothrombin, or factor 2, to thrombin, or 2A. Thrombin then hydrolyzes arginine-glycine bonds of fibrinogen to fibrinopeptide A and B to form fibrin monomers. Hydrogen bonds then link these monomers to form loose, insoluble fibrin polymer. Factor 13 is activated by thrombin and stabilizes this fibrin polymers by covalent bond crosslinks. Thrombin also has direct effects on other clotting factors in addition to fibrinogen and factor 13. It amplifies the activation of factor 5, 8, and 9. Factor 10A is the crucial step. It is the only physiological activator of prothrombin.
Great. The comprehensive knowledge of clotting cascade or coagulation pathways is very essential for the primary exam. Now, another commonly asked pathway is the fibrinolytic pathway. So can you please outline the steps in the fibrinolytic pathway?
The fibrinolytic pathway is a highly regulated enzymatic process that degrades and removes fibrin clot and thus counterbalances the coagulation pathway. Fibrinolysis is also activated upon vessel injury, but is inhibited by the thrombin generated by the coagulation cascade. Once the initial stimulus for clot formation is diminished or removed, thrombin generation is reduced and the balance favours fibrinolysis. Fibrinolysis involves the release of plasminogen activators, plasmin formation from plasminogen, and clot lysis. So firstly, release of plasminogen activators. Injured endothelial cells express tissue plasminogen activator on their surface and secrete this into plasma. Tissue plasminogen activator is the primary plasminogen activator. The endothelial cells also activate factor 12, as outlined above, and release bradykinin during the breakdown of high molecular weight kininogen. Bradykinin stimulates TPA, nitric oxide, and prostacyclin release from endothelial cells, all of which inhibit platelet. Factor 12A and kallikrein are also direct plasminogen activators. The next step is plasmin formation from plasminogen. Plasminogen binds to fibrin and the plasminogen activators cleave bound plasminogen to form plasmin. Plasminogen activators are only able to activate bound plasminogen. The final step is clot lysis. Plasmin cleaves cross-linked fibrin and fibrinogen, resulting in fibrin degradation products such as D-dimer and degradation of the clot. Thicker strands or denser networks of fibrin are more resistant to fibrinolysis.
Thanks, Maddie. So on one side, body has these mechanisms to prevent bleeding and by forming the clot. But at the same time, body also has mechanisms of preventing thrombosis or clot formation. Can you please describe those mechanisms?
So Virchow's triad describes 3 broad factors that contribute to the development of thrombosis. These are stasis, endothelial injury, and hypercoagulability. The body's mechanisms to prevent thrombosis therefore targets these 3 factors. So the first factor is stasis, and continuous blood flow throughout the body helps target this by washing away and diluting active mediators that may form thrombus. The second factor is endothelial factors, which target endothelial injury. So vessel walls are usually smooth, which prevents activation of the intrinsic system. There is also thrombomodulin, which all endothelial cells, except those in the cerebral microcirculation, produce. And thrombomodulin is a thrombin-binding protein, which activates protein C system. While thrombin is a procoagulant, when it is bound to thrombomodulin, it becomes an anticoagulant, as the thrombomodulin-thrombin complex activates protein C. Activated protein C and the cofactor protein S inactivates factor 5 and factor 8 and inactivates an inhibitor of tissue plasminogen activator, therefore increasing the formation of plasmin. As we have described earlier, plasmin is an active component of the fibrinolytic system which lyses fibrin and fibrinogen, thereby preventing clot. Plasminogen receptors are also located on the surface of many types of cells, including the endothelium. When plasminogen binds to these receptors, it becomes activated, which discourages clot formation in the intact vessel. Furthermore, the absence of damage to blood vessels prevents blood being exposed to collagen. Therefore, von Willebrand factor cannot bind, and without injury, there is no exposure to tissue factor. Therefore, the extrinsic pathway isn't activated. Furthermore, there's a glycocalyx, which is the mucopolysaccharide coating the vessels, which repels platelets and coagulation factors. And prostacyclin is also produced by the vessels, which inhibits platelet aggregation by increasing platelet cyclic AMP and causing relaxation of vascular smooth muscle. Furthermore, nitric oxide is also produced, which inhibits platelets by increasing platelet cyclic GMP and causing vasodilatation. The third factor are natural anticoagulants. These include heparin sulfate, which is a linear polysaccharide expressed on cell surfaces, which enhances the activity of circulating antithrombin 3. Antithrombin 3 is a small glycoprotein which inactivates several enzymes in the coagulation cascade, most importantly thrombin and factor 10A. Protein C and protein S are also natural anticoagulants, as outlined earlier. The coagulation factors that we've described before also circulate in an inactive form, and the plasma itself contains inhibitor systems, which helps to ensure that the coagulation cascade isn't inappropriately activated. Finally, there's a tissue factor pathway inhibitor, which inhibits the activity of factor 7A tissue factor complex, and thus the activation of factor 10 via the extrinsic pathway.
Thanks, Maddie. So again, it's important to have the comprehensive understanding of the clotting pathways and also the mechanisms which prevent clotting in the body. But also it's important to have a very comprehensive understanding of the tests that we perform in ICU to assess coagulation. And the commonly performed tests are prothrombin time, activated partial thromboplastin time, and activated clotting time, and INR. So can you please outline how the following tests assess coagulation: PT, APDT, INR, and ACT, or activated clotting time?
So the prothrombin time, it focuses mainly on the extrinsic pathway and the common pathway. Blood is collected in a tube containing citrate, which binds the calcium and prevents the clotting process from beginning before the test can commence. The blood cells are then separated from the plasma by centrifuge. Tissue factor and calcium is then added to the plasma sample, and the time taken for the clot to form is measured. The rate of clotting via this extrinsic pathway is mainly influenced by the amount of factor 7 available, which has a short half-life and depends mainly on vitamin K. Testing prothrombin time is mainly a function of the vitamin K-dependent enzymes 2, 7, and 10. 9 is also a vitamin K-dependent enzyme, but is not tested by prothrombin time. Prothrombin time also tests factor 5 and fibrinogen. Causes of an isolated prolonged prothrombin time include factor 7 deficiency, warfarin, liver disease, paracetamol toxicity, and mild vitamin K deficiency. An INR is related to the prothrombin time. This is a ratio of a patient's prothrombin time to a control prothrombin time. For example, an INR of 2 means blood clotting is twice as slow as a normal blood. The APTT mainly focuses on the intrinsic pathway and the common pathway of coagulation. Phospholipid, calcium, and an activator, such as kaolin, which is a negatively charged particle, are added to platelet-poor plasma, and the time taken for formation of a fibrin clot is measured. APTT evaluates factor 12, 11, 9, 8 of the intrinsic pathway, as well as 10, 5, 2, and fibrinogen from the common pathway. Causes of an isolated elevated APTT include factor 8, 9, 11, or 12 deficiency, von Willebrand disease, antiphospholipid antibodies, heparin, and factor inhibitors to factors in the intrinsic pathway. The activated clotting time is a point-of-care test done when very high doses of anticoagulation, mainly heparin, are being used, for example, during bypass or ECMO. Fresh whole blood is added to a tube containing a surface activator such as glass balls or kaolin. This activates the intrinsic and then the common pathway. Causes of a prolonged ACT include heparin, hypothermia, low levels of fibrinogen, clotting factor deficiencies, factor 7 or 13, thrombocytopenia, or platelet dysfunction.
Thanks, Maddie. So we do ACT very commonly, as you mentioned, in the patients who come from cardiothoracic surgery, like bypass, or patients who are in ICU on ECMO. Because it's a point of care test, it's very quickly available at bedside and can be done in a few minutes. So having an understanding of ACT versus APTT is important because both tests can be performed when the patient is on heparin. Now, another point of care testing that we perform in ICU or in theaters is ROTEM. Now, this test has been popularized in last decade or so, and especially in the context of trauma patient or high risk surgical patients where they are at risk of bleeding. Especially the anesthetic colleagues love this test. So can you please describe the principles and different measurements that we perform in ROTEM?
So rotational thromboelastometry, or ROTEM, is a whole blood viscoelastic hemostasis analyzer. So whole blood is added to a heated cup at 37 degrees. A pin is suspended within the cup and continuously oscillates. As the blood clot, fibrin strands form between the cup and the pin, which then impede rotation of the pin. This impediment is detected and a trace and waveform is then generated. ROTEM provides information about clot formation, propagation, strength, and lysis, and can be used to guide transfusion strategy. It measures certain variables. So it measures the clotting time, which is the time from the start of the test to when the waveform reaches 2 millimeters above baseline. Prolongation of the clotting time may indicate a deficiency of coagulation factors or presence of anticoagulants. The clot formation time is the time from 2 millimeters above baseline to 20 millimeters above baseline. An increased clot formation time generally reflects either fibrinogen or platelet deficiency. The alpha angle is the angle of tangent at 2 millimeters amplitude. If this is low, generally there is a fibrinogen or platelet deficiency. If this is high, generally the patient is in a hypercoagulable state. The maximum clot firmness is the maximum strength of the clot. If this is low, then there may be a deficiency of either platelets or fibrinogen or both. The A5 or the A10 is the amplitude of the clot at 5 or 10 minutes. The Ly30 is a lysis index at 30 minutes. This is the percentage reduction in maximum clot firmness that exists 30 minutes after clotting time. And finally, the maximum lysis is the maximum fibrinolysis detected during the whole measurement. If this is high, it suggests hyperfibrinolysis. ROTEM has 6 separate assays which can be used to help isolate different parts of the coagulation system. The INTEM uses phospholipid and ellagic acid and is similar to the APTT and in testing the intrinsic pathway. The XTEM contains tissue factor as an activator and is similar to the PT, testing the extrinsic pathway. The HepTEM contains heparinase, which neutralizes the effects of heparin. Therefore, if the HepTEM clotting time is much shorter than the INTEM clotting time, it would suggest ongoing heparin effect. The APTEM is the same as the XTEM, except it contains aprotenin, which inhibits fibrinolysis. If the clotting time is shorter and the MCF is higher with APTEM compared to XTEM, it would suggest hyperfibrinolysis. The FibTEM is similar to the INTEM but contains cytochalasin D, which inhibits platelet contribution to clot formation and therefore is an assay which just assesses the fibrinogen component of the clot. And finally, ectotem contains eccarin, which activates prothrombin. It will be prolonged in the presence of direct thrombin inhibitors, but normal in the presence of heparin.
Thanks, Mary. That's a very comprehensive answer. And I must admit that I was not even aware of these different assays that we perform in ROTEM. So thanks for enlightening me as well with this extra knowledge. So we're coming to our last part of the podcast. And as you mentioned, probably we got 50,000 downloads because of your very popular jokes.
I don't sound so enthusiastic.
Look, I think we have to find something to give credit to, So yeah. So let's continue with the tradition. So what's the joke for this month?
Okay. So why can hematologists always make money?
Okay. I'm not sure why you are fascinated with some specialty making more money, because this is the second time you asked me this question. Some specialty making more money. Hematology making money must be related to something related to the blood. Is it because they produce blood?
No, because they know blood cells.
Thanks, Maddie. That is very intelligent joke. It took a while for me to get that, but thanks for explaining before the podcast to me.
Oh, that's all right.
I wouldn't have got this joke. So thanks, folks. Thanks for listening to our podcast. This is the end of this month's podcast. We'll be back in month's time with another episode on ICU primary physiology. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.